So this is one of the videos that I am not planning to make public, so if you're watching it, either I sent it to you or for some reason I decided to publish it, but I'm going to make a video about soft tissue sarcomas because I hate this topic. And I just got a question yesterday on SCORE that really pissed me off, but I feel like is actually a very possibly testable question. It's like not only do you have to know about soft tissue sarcomas, which everybody hates, but you also have to know something really detailed about them, which is which ones spread via lymphatics and which ones spread hematogenously. So soft tissue sarcomas usually spread hematogenously, not by lymphatics. And first of all, the lung is the most common site for metastases. And so they had a question where this patient had a soft tissue sarcoma and then they had palpable lymph node. And then the question was like, which one of these is it most likely to be? And for me, I didn't really think about the way that they spread hematogenously versus lymphatically. I was kind of thinking more along the I guess demographics of the patients because for adults the most common is malignant fibrous histiocytoma, but it was wrong because this question was actually basically testing your knowledge of which one of these are traveling lymphatically instead of hematogenously, which is what they normally do. And so basically, long story short, generally, soft tissue sarcomas do not spread to lymph nodes, but there are a few that are more likely to have lymphatic spread. These include rhabdomyosarcomas, epithelioid sarcomas, clear cell sarcomas, synovial sarcomas, and vascular sarcomas. Since I got that question and since it pissed me off, I may as well just make a video about soft tissue sarcomas in general. And like I said, for these videos, a lot of times I just read from different resources or I just talk about things. So if you're watching this, that is your warning. So the most common soft tissue sarcoma in adults is malignant fibrous histiocytoma, and the second is liposarcoma. And then the most common in kids is rhabdomyosarcoma. 50% of these will arise from extremities, 50% arise in children, and these arise from the embryonic mesoderm. So symptoms of soft tissue sarcomas, they mostly present as an asymptomatic mass. Most are large, most grow rapidly, and most are painless. Some can cause GI bleeding, bowel obstruction, neurodefects, and staging is based on grade, not size. And tumor grade is the most important prognostic factor. I think I've seen that on a question before. So undifferentiated tumor grade obviously has a worse prognosis. One thing that I always get really confused about is how you biopsy these soft tissue sarcomas, and I think it's because everybody beats into the ground that you do a longitudinal incisional biopsy if it's greater than 4 centimeters, and you have to do it longitudinally so that you don't mess up the lymphatics. But the thing is, like, that's not your initial way that you prefer to diagnose these. You actually prefer to do a core needle biopsy. That is the best test. It's your first test and it's your best test. And then if that fails, then you do excisional biopsy if the mass is less than 4 centimeters and a longitudinal incisional biopsy for masses larger than 4 centimeters. So the reason why you do this longitudinal incisional biopsy is because you eventually will have to resect the skin site if the biopsy ends up showing sarcoma. Also, if you biopsy along the long axis plane, you'll have less lymphatic destruction and make the site easier to close in the future. Other workup. Fiser says you need a chest x-ray to rule out lung metastasis, but I got a SCORE question where they said the answer was CT chest to rule out lung mets, but I doubt that they'll give you both of those. If both of them showed up, I would probably choose CT, but that's just me. You also want to do an MRI before you do the biopsy to rule out vascular, neuro, or bone invasion. Corneal biopsy that I talked about is 95% accurate. So they talk about how these spread hematogenously, not to lymphatics, and mets to the nodes is really rare. The lung is the most common site for metastasis. I think I said that already. Okay, treatment for these. You want at least 2 to 3 It says 2 to 3 margins. I think it means 2 to 3 centimeter margins and at least one uninvolved fascial plane. Try to perform a limb sparing operation. Try to place clips to mark sites of likely recurrence because you will irradiate these later. For post-op radiation, you do that for high-grade tumors, close margins, tumors greater than 5 centimeters, and chemo is doxorubicin based. Tumors larger than 10 centimeters may benefit from pre-op chemoradiation. This may allow limb-sparing resection, and 90% do not require an amputation. That's pretty good. Isolated sarcoma metastases without other evidence of systemic disease can be resected. This is the best chance for survival. Otherwise, you can palliate with radiation. For pelvic and retroperitoneal sarcomas, the favored incision is a midline incision. With resection, try to preserve motor nerves and retain or reconstruct vessels. It doesn't really tell you when you would use chemotherapy, though. It doesn't tell you if you, I guess only for pre-op chemo rads. It doesn't say anything about just using chemo as adjuvant therapy or just as neoadjuvant by itself. When you're doing your incisional biopsy, there should be no raising of flaps or disturbance of tissue planes superficial to the tumor. The mass should not be enucleated within the pseudocapsule. Rather, incisional biopsy leaving the bulk of the lesion undisturbed should be carried out. Before wound closure, hemostasis should be achieved to avoid a hematoma, which could disseminate tumor cells throughout normal tissue planes. Drains are not used routinely. Factors that worsen prognosis are delay in diagnosis, difficulty with total resection, difficulty getting radiation to pelvic tumors. Chemo and radiation have not changed survival. Great. And there is apparently a 40% 5-year survival rate with complete resection. Wow, that sucks. So then there's a page basically just of different sarcomas where they just list a bunch of facts, and I'm just going to read this. I wrote this in the margin about desmoid tumors. I think I got it from a question at some point, probably from SCORE. Desmoid tumors, or aggressive fibromatosis, are locally infiltrating tumors with no potential for mets. They don't need staging studies. They are locally aggressive and have a high rate of recurrence even after resection. Okay, head and neck sarcomas are usually in the pediatric population. They are usually rhabdomyosarcoma. It's hard to get margins because of proximity to vital structures. Post-op radiation is used for positive or close margins, as negative margins may be impossible to obtain. Next, they talk about retroperitoneal sarcomas. Most commonly, these are leiomyosarcomas and liposarcomas. These have a poor prognosis due to delayed diagnosis and incomplete resection. There's also difficulty getting radiation to the tumor due to proximity to vital structures. Ability to completely remove the tumor is the most important prognostic factor, and you need to rule out lymphoma in this location, which is the most common retroperitoneal tumor overall. Risk factors for some of these: asbestos is a risk factor for mesothelioma, PVC and arsenic are risk factors for angiosarcoma, and chronic lymphedema is a risk factor for lymphangiosarcoma. Okay, so next they talk about Kaposi's sarcoma, which is a vascular sarcoma. It's caused by HHV8. It most commonly involves the oral and pharyngeal mucosa, but they can also involve the legs, the face, and the genitalia. You get bleeding, you get dysphagia. It's associated with immunocompromised state and is the most common malignancy in AIDS. However, it's a rare cause of death in AIDS because it's a very slow-growing lesion. I have written in my margin, cutaneous lesions, asymptomatic, elliptical, arranged linearly, color changes from light brown to violet, start as papules and later become plaques or nodules. Do with that information what you will. Primary goal is palliation. AIDS treatment with the antiviral retrograde, whatever it stands for, is the best treatment. It shrinks AIDS-related Kaposi sarcoma. Consider radiation or intralesional vinblastine for local disease, interferon alpha for disseminated disease, and surgery for severe intestinal hemorrhage. Next, they talk about childhood rhabdomyosarcomas. This is the #1 soft tissue sarcoma in kids. It occurs in the head and neck, in the genital urinary system, in the extremities, and in the trunk. The trunk has the poorest prognosis. The embryonal subtype is the most common, and I think it has a slightly better prognosis. The alveolar subtype has the worst prognosis. Rhabdomyosarcoma contains desmin. I'm guessing that they're telling you that because it stains positive for desmin, but it doesn't actually say that in here. But if you see some question with immunohistochemistry and desmin is one of the answers, that's probably what it is. Botryoides tumor is a vaginal rhabdomyosarcoma. Treatment for these is surgery and doxorubicin-based chemotherapy. Angiosarcomas can be associated with radiation. Treatment: neoadjuvant chemo with taxane, and then resection. If after breast-conserving treatment, then need a total mastectomy. That was a margin note. Bone sarcomas are mostly metastatic at the time of diagnosis. Osteosarcomas have an increased incidence around the knee. They originate from metaphyseal cells. They usually occur in children. And then they mention genetic syndromes for soft tissue tumors. These include neurofibromatosis, which includes CNS tumors, peripheral sheath tumors, and pheochromocytoma. Li-Fraumeni syndrome, which is associated with childhood rhabdomyosarcoma, and many others is what they say. Hereditary retinoblastoma, which also includes other sarcomas. Tuberous sclerosis is associated with angiomyolipoma. Gardner's syndrome is associated with familial adenomatous polyposis and intra-abdominal desmoid tumors. There are some other conditions that I'm just going to read about because I'm not going to study them otherwise. Lip lacerations, important to line up the vermilion border. Xanthoma, which are cholesterol rich, are yellow, contain histiocytes, and are benign. Warts, aka verruca vulgaris, are viral in origin. They're contagious, they're auto-inoculable, and they can be painful, and you treat these with salicylic acid and liquid nitrogen. Lipomas are common, but they're rarely malignant. They are found in the back, the neck, between the shoulders, and they are the most common mesenchymal tumor. Neuromas can be associated with neurofibromatosis and von Recklinghausen's disease, which is also characterized by café au lait spots, axillary freckling, peripheral nerve, and CNS tumors. And then I wrote down Perniciae. That one they love to ask questions about is the most common hand soft tissue infection, comprising 35% of all hand infections. The most common pathogen is Staph aureus, but others can be caused by strep, enterococcus, and pseudomonas. All right, last page. Dermatofibrosarcoma protuberans. Most common in adults in the 3rd to 5th decade. They present as a firm, flesh-colored to dull red plaque. They can be mistaken for keloids or hypertrophic scars. Histology will show finger-like projections of spindle cells, which likely account for tumor recurrence. These rarely metastasize if there's no fibrosarcomatous change, but they recur locally. If there's fibrosarcomatous change, there's increased risk for Mets, usually to the lung, and it's associated with the T1722 translocation. Actinic keratosis is premalignant in some damaged areas. This is premalignant for squamous cell carcinoma, I remember. Need excisional biopsy if suspicious. Treatment is diclofenac sodium and liquid nitrogen. Seborrheic keratosis is not malignant. It can be found most often on the trunk in the elderly and can be dark. Arsenical keratosis is associated with squamous cell carcinoma. And that's all they say about that. Merkel cell carcinomas are neuroendocrine. They're a very malignant tumor with early regional and systemic spread. They have red to purple papulonodules or indurated plaques, and they're located subcutaneously. They have neuron-specific analase. This is important. I've seen it before. These stain positive for neuron-specific analase. They also contain cytokeratin and neurofilament protein. All of these patients get a sentinel lymph node biopsy or a formal lymph node dissection. If you have positive clinical lymph nodes or on the sentinel biopsy, you'll get a lymph node dissection or radiation to the nodal basin. Treatment for these is wide local excision. You need 2 to 3 centimeter margins. They're very radiosensitive. You need adjuvant radiation for stage 2, which is greater than 2 centimeters without lymph node mets, or stage 3, which is any tumor size with lymph node mets. Did that make sense? Let me say that again. You need adjuvant radiation for Merkel cell carcinoma if it is stage 2, which is greater than 2 centimeters without lymph node mets, or if it's stage 3, which is any size with lymph node mets. So what that means to me is if it's 2 centimeters or bigger, if there's any nodes, they get adjuvant radiation. Glomus cell tumors. They're painful tumors composed of blood vessels and nerves. They're benign, most common in the terminal aspect of the digits. Treatment is tumor excision. Desmoid tumors, which I had written in my margin earlier, I don't know why. They're benign, but they're locally invasive. They arise from connective tissue. The most common location is the anterior abdominal wall. Desmoids can occur during or following pregnancy. They can also occur after trauma or surgery, and they occur in fascial planes. Intra-abdominal desmoids are associated with Gardner syndrome and retroperitoneal fibrosis. They often encase bowel, making it hard to get unblocked resection. There is no distant spread, however, there's high risk of local recurrences. Treatment, if possible, is surgery. Otherwise, you can do chemo with Slindac or tamoxifen. And when they do this, they say Slindac, tamoxifen. I don't know if that's both or if that's one or the other. So just keep that in mind. You may see it as both on the exam or as one or the other, and I cannot be bothered to look that up right now. If a vital structure is involved or too much bowel would be taken, aka they would be at high risk for short bowel syndrome with surgery, then you do chemotherapy. Bowen's disease is squamous cell carcinoma in situ. 10% turn into invasive squamous cell carcinoma associated with HPV. Treatment is imiquimod, cautery ablation, topical 5-fluorouracil. Avoid wide local excision if possible. There's a high recurrence rate with HPV, and you need to do regular biopsies to rule out cancer. Keratocanthoma, characterized by rapid growth, rolled edges, crater filled with keratin. It is not malignant, but it can be confused with squamous cell carcinoma. It involutes spontaneously over months. Always biopsy these to be sure. If they're small, excise them. If they're large, biopsy and observe. Hyperhidrosis is increased sweating, especially noticeable in the palms. Treatment is thoracic sympathectomy if refractory to a variety of antiperspirants. Hidradenitis is infection of the apocrine sweat glands, usually in the axilla and groin. Pathology is lymphocyte perifolliculitis with follicular hyperkeratosis. Risk factors include excessive use of deodorant and antiperspirants, Down syndrome, being an African American, being female, and being obese. Staph and strep are the most common organisms. It says avoid antiperspirants. Treatment is antibiotics and improved hygiene first. May need surgery to remove skin and associated sweat glands, and you excise from the skin to the fascia. And I just got a question on this, and I saw it in real life. You would do a split thickness skin graft if you had to cover the area that you excised. Almost done. Benign cysts. Epidermal inclusion cysts are the most common. They have completely mature epidermis with creamy keratin material. These are the ones with the cheese-like, foul-smelling stuff when you accidentally get into it. It's associated with Gardner syndrome. You have to excise the cyst wall and the contents. If you leave the cyst wall, there are risks for recurrence. Tricholemal cyst is in the scalp. No epidermis. Contain keratin from hair follicles. That's all I say. Ganglion cyst, over joints, usually the wrists, filled with synovial fluid. Aspiration cures 50%. Need to remove the check valve with surgery. I don't know what that is, and I'm not going to find out. Dermoid cysts, midline, intra-abdominal, and sacral lesions usual. Need resection due to malignancy risk. Pilonidal cysts, congenital coccygeal sinus at the sacrococcygeal junction with ingrown hair that gets infected and needs to be excised. That's it. That's the end of the soft tissue sarcoma chapter, which is good because I can't do this anymore. I'm gonna go take a nap. If you're watching this, I honestly don't know why. My recommendation to use this video, which is what I'm going to do, is to play it in the background while you're doing something else. Maybe you'll pick up a random fact. Maybe that random fact will show up on the ABSITE, or maybe you'll see that random fact again somewhere else, and it'll stick because you heard it on this boring video. If you can remember it from this video, you can remember it from anywhere. So if you did watch this, thank you for watching, and have a great morning.